Thank you so much. And I realize I am what is standing between you and those lovely little lunch packets over there on my left. So I will try to keep this to the point so that we can all continue. This has been a really wonderful day so far, and I'm just honored to be able to talk to you all about how we have really been able to leverage protein discoveries over the past couple of years to make a major shift in the way we think about Parkinson's disease, but then also how we are actually starting to implement clinical trials, which hopefully will ultimately change the way that we treat patients. These are my disclosures. So imagine with me for just a moment. A 50-year-old woman goes to see her primary care doctor for a well checkup. They discuss her cardiovascular risk. They maybe check a lipid profile, do other types of cardiovascular screening, talk about her risk of heart disease, and come up with a personalized plan to prevent cardiovascular disease in the future. They talk about her cancer risk. Maybe they talk about her genetic background of cancer, as well as other exposures during her life that increase her cancer risk. And they come up with a personalized approach to preventing cancer within her. They then talk about neurodegenerative screening. They maybe do plasma or other types of profiling, talk about genetic and exposure risk, and come up with a personalized approach to preventing neurodegenerative diseases, such as Alzheimer's disease, Parkinson's disease, and others. This is where we want neurodegenerative diseases to be. We need neurodegenerative diseases to move from symptomatic therapies to preventative medicine. We need neurodegenerative diseases to be part of the standard screening protocols that are happening every single day in our primary care clinics. But we need to have ways of actually preventing them. And before you can prevent something, you need to know that it exists. And that's where we are today when it comes to neurodegenerative diseases, is simply trying to identify who those people are who have the disease but do not have clinical manifestations yet. Just like we know the people who have increased lipids and probably have plaques, but don't have a heart attack yet, right? That's what we need to do in neurodegeneration. Who are the people who have changes in their brain that are already occurring that probably are on the path to these neurodegenerative diseases, but they're not there yet? So this is a commonly used profile of Parkinson's disease that looks at some of what we consider this premotor phase, this time when we believe that the pathology begins, some of the first clinical symptoms being constipation, and then things like REM sleep behavior disorder, loss of smell, excessive daytime sleepiness, sleep dysfunction, depression, all of these things on this part of the graph we know happen to our patients before they have the first tremor, the first change in their walking. But we can't tell the difference between someone who has constipation due to this onset of Parkinson's disease versus someone who has constipation due to the million other reasons why constipation occurs in the aging population. And so this is the part of what we call the premotor, the prodromal. There's like 100 different terms for it right now that we really need to be able to identify. This is where I live my life in the clinic once someone has clinical manifestations. And this is still a very, very important part of the curve. And this is where we're treating patients today. But if we're ever going to talk about actually having a preventative plan for neurodegenerative diseases, we need to get to the left side of this curve. We need to be able to get to a place where we can identify these individuals, identify when they're going to actually develop clinical symptoms, and how they're going to have targeted therapies. So this is what I've been working on with a group of many other people across the world, most of it funded by the Michael J. Fox Foundation over the past couple of years. So, and we have our first publication, which was called The Biological Definition of Neuronal Alpha-Synuclein Disease Toward an Integrated Staging System for Research, is our first pass at trying to actually come up with a framework that will allow us to do this and shift from symptomatic therapies toward this idea of preventative medicine. So this is where Parkinson's disease is right now. So this clinical diagnosis of bradykinesia, rigidity, tremor, gait and balance abnormalities that we look at in the clinic. But the challenge is, of course, there are many, many, many things that actually cause this clinical syndrome of Parkinsonism. And the actual underlying pathologies for all of these different things are quite varied and probably would respond to extremely different preventative therapies, even within the construct of alpha-synuclein Lewy body-based Parkinson's disease itself. There's probably many different forms of that biology that are occurring, many proteoforms perhaps, that we need to understand that different people would respond to different types of therapies. And so we are quite many steps away from getting to that point, but we're taking those first shifts there. Even within the idea of this clinical diagnosis of dementia with Lewy bodies and the clinical diagnosis of Parkinson's disease, these actually have the same underlying biologies once you get to the end of life and you go to autopsy. But the clinical symptoms are just slightly different. One of them has a motor manifestation first, the other has a dementia manifestation first, probably due to the way that the underlying biology simply spreads in the brain, the cortex versus the motor circuitry, but actually has a lot of common overlap. And in fact, when we think about the spectrum of these non-motor symptoms, in particular, those that can precede the motor diagnosis, most of them are these non-motor symptoms that probably don't live in the motor system. And so we really have created this construct of these different diseases based on these clinical symptoms and not at all based on the biology, and not at all based on the different biological markers, which we need to identify through things like proteomics. This is just to throw out the very complex diagnostic clinical criteria that I use in clinic. This is the one for dementia with Lewy bodies. It's pretty terrible. And really, again, when it comes right down to it, just comes down to whether or not there is this cognition first versus this motor first syndrome, but really is very difficult to identify patients who have these syndromes versus other neurodegenerative syndromes. And so when we get down to it, these complex neurodegenerative diseases that clinically have this very integrated cognitive, sleep, motor, non-motor, neuropsychiatric symptoms, and have a lot of different clinical terms. As far as we know right now, really just have one end pathology, and that is neuronally centric aggregates of alpha-synuclein. Now, there's probably a lot more very complex biology that actually differentiates the people who have more of a motor first versus cognitive first versus autonomic first. But at the moment, we really can't differentiate those based on their biologies whatsoever. And that's work that, again, probably needs to be done at a molecular level to understand, again, is this driven by other things besides alpha-synuclein aggregation that's happening? Is this different versions of alpha-synuclein aggregation that's happening in the neurons that lead to these different syndromes? But it's important that the shift happens so that it is based on the biology versus based on the clinical syndromes, because we're probably only separating the different types of disease based on clinical syndromes by about, we're probably capturing the actual biological differences maybe by 60 to 70%. But that's not how we're going to have therapies. Therapies need to be based on the different underlying biologies. So how do we get from this side of the curve to actually thinking about the entirety of the disease, whether you have symptoms or not, based on the biology? And that's really the shift that's happening within neurodegenerative diseases. As a neurologist, I was trained to identify the disease based on the clinical symptoms. And if you did not have the clinical symptoms, you simply did not have disease. But we know that that's not true, right? We know that there's biology that's happening underneath that is leading people to have clinical symptoms. And once we start thinking as clinicians that the biology is actually the disease, we can start working with people who are focusing on that biology to identify that disease in our patients. And so here we have termed this concept neuronal alpha-synuclein disease, which encompasses what is now clinically referred to as clinical Parkinson's disease, clinical dementia with Lewy bodies, and all of the related symptoms. And the reason this was important that we sort of put this under a new umbrella is because we wanted this to identify individuals who had evidence of the biological disease independent of any of their clinical symptoms, including individuals who have absolutely no clinical symptoms, because we can't even start to think about doing clinical trials of prevention until we can identify people with disease but no clinical symptoms. So this has really become possible in the past couple of years because, previously I couldn't actually say whether my patient had aggregated alpha-synuclein until they came to autopsy, which is quite late for a preventative therapy. So what we have finally identified is using this synuclein seed amplification assay, which for those of you who aren't familiar, this takes the cerebral spine. Right now, it's only really validated on CSF, but people are using other matrices to try to make this work, where you take the CSF of a person, you use these seeds with the thioflavin tag. You go through this shaking fragmentation elongation process. You have a fluorescence readout, and you basically get a binary outcome. It's either detected, meaning that that sample had alpha-synuclein in it that was prone toward aggregation, or it is not detected, meaning that CSF did not have alpha-synuclein prone toward aggregation. We know the CSF has alpha-synuclein in it. We can actually measure that, but whether or not it is prone toward aggregation or not is the new readout. And so this is a sledgehammer of a outcome, right? It's a binary yes, no. It doesn't tell you anything about quantity or severity or anything like that. But it's a heck of a lot better than, having to wait till your patient goes to autopsy to have an answer. And it's a pretty accurate outcome, actually. We have found remarkable accuracy. We have the data from the Fox Foundation PPMI study, the 22 patients who have now gone to autopsy, 20 of whom had a positive assay at the time of diagnosis, all had verified neuronal inclusions of alpha-synuclein at death 10 plus years later, and the 2 that were synuclein negative, despite having a clinical diagnosis of Parkinson's disease, did not have Lewy bodies at autopsy. And so our concordance between CSF and final autopsy at this point in time is 100%. Now, we've sort of put this for now because we understand that you're never going to have CSF as a screening tool in, you guys are talking about like these TATSO devices and stuff, and I'm doing LPs on people still. So we're a long ways away from getting to a point where we can actually get this in blood and plasma, but this is something that people are really working toward. In addition, while this is just this is a sledgehammer, it's a yes, no, that's all it tells you. There's nothing about the proteoforms. There's nothing about what else is going on. It's simply giving you one marker as a binary outcome. But again, it's a big deal, and it helps us tremendously. The other piece of this is that we recognize that the loss of dopaminergic neurons in the nigrostriatal system also tells us something very important about the functionality. And so we've included dopamine imaging as a second biomarker for this neuronal synuclein disease. Again, for now. And so we have this biological definition where we've simply gone from being able to detect at autopsy what my pathology colleagues like Tom Montine would read out is patient had nigrostriatal degeneration, and they have alpha-synuclein staining positive aggregates in the neurons, throughout these different parts of the brain. We can now say that in someone who is alive, which is actually a huge, huge change in the field. However, again, these are just very crude measures at this point in time. And so what we've put together is this construct of an integrated staging system where we are using these biomarkers finally to be identifying people throughout the entire life cycle of these diseases. And this is a very similar staging system to what has been developed now in Alzheimer's disease as well as Huntington's disease. We purposely did this in a very similar fashion because ultimately what we want to think about actually is just neurodegenerative diseases of aging in a broad sense and not clustered by their clinical symptomatology. Because again, if you're going to do screening in a healthy older adult, you're not thinking about tremor or dementia, you're thinking about neurodegeneration and you don't know how it's going to manifest. So this is the staging system that's being used across, again, these 3 diseases for now, hopefully more in the future, where we have this concept of a stage 0, where individuals only those who have this fully penetrant deterministic gene, which is very, very rare in Parkinson's disease and Alzheimer's disease, but there's a handful of genes out there that count for this. In Parkinson's, it's really just the SNCA gene that we considered here. Stage 1 are individuals who are completely asymptomatic, but have biomarker evidence. So these are the individuals who are coming out of these healthy brain aging cohorts, such as the Stanford Aging and Memory Study, the Stanford Alzheimer's Disease Research Center, many of these other healthy aging cohorts that are finding somewhere between 5 to 8% of individuals are synuclein positive, yet have absolutely no symptoms whatsoever. These are the people that we have the opportunity for prevention in. We just don't understand how long they're synuclein positive and where they are in the disease process before they get symptoms. Stage 2 are those individuals who have those very, very mild symptoms: sleep disturbance, loss of smell, constipation, but no tremor, no movement problems, and they have perfectly normal memory. These are individuals that right now we're actually able to find in these older cohorts, and the Fox Foundation again is actively recruiting these individuals because we're actually going into the very first clinical trial in these individuals as a potential prevention therapy in 2025, which will be the first prevention clinical trial that will happen within this construct. And then stage 3 is the different stages of functional impairment as we think about individuals who now do have what we consider clinically manifest symptoms, going from slight, mild to moderate to severe. But as we think about across this entire staging system, you'll see just a bunch of pluses, because that's the level of detail we're at right now, that once you're synuclein positive, you're in the staging system. And we don't have any way to differentiate as people go across this scale who's sort of in the more severe stages. And while at the early stages, most people don't have dysfunction of their dopamine because that's very closely linked to the actual clinical symptomatology, once you get to the later stages, everybody's dopamine positive. And so there's an enormous amount of work to be done, particularly here in the early areas, once we start identifying these folks who are clinically pretty normal, but are synuclein positive, sort of understanding the different gradations. And I'll show you one example of a new biomarker that we've identified that's giving us a little bit of information about this stage. It's also very important that we understand these people who go from stage 1 to stage 2 as they go from asymptomatic to those very, very mild symptoms and catching them very early. We actually think this is an incredibly important phase where we do more functional monitoring, because there could be very, very slight changes in gait pattern, very slight changes in steps per day, very slight changes in functional activity that might herald the transition here from a stage 1 to a stage 2 individual. And then this is where we have the most challenges, because we have absolutely no biomarkers or biological anchors to tell us when somebody is going from a clinically manifest disease through severe end-stage disease. And so a lot of work that still needs to be done in this area as well, ideally as using these as endpoints for clinical trials. And so in addition to synuclein and dopamine, of course, there's a ton of other biological processes that are going on in these patients. And we haven't even begun to come up with ways that we can clearly identify how these changes in immune function and mitochondrial function, lysosomal markers, all of these different areas are contributing to patients progressing along that staging system. So there's a lot of opportunities to build these other markers into the system. Again, this is just meant to be a framework that today is anchored on synuclein and dopamine because that's what we can measure. But until we can get these other markers, we have more opportunities to build this out. So I'll just end with one example of something that I was working on for the past couple of years with some colleagues here at Stanford. So back in, it was pre-pandemic, I think it was 2018, 2019, one of the postdocs in Tony Weiss-Corey's lab came to me and said, we've got, I see something in the Olink data that's come out of the ADRC. This is Benoit, and he identified that there was a signal that he was seeing in the PD patients compared to the healthy older adults and the Alzheimer's disease patients. And then a fabulous graduate student in Tony's lab, Jared, sort of took it from there and helped us to sort of flesh out this entire story. So I'll walk you through what they found. And in fact, there are several other labs simultaneously that also identified this. So using the Olink proteomic data and this about 200 samples throughout the Stanford data set, what Benoit identified is that DDC, or dopamine decarboxylase, was identified as a very, very strong marker that differentiated our Parkinson's cohort from our healthy controls. And when we first saw this, I was a little surprised this hadn't been identified before. And in fact, we even saw it in plasma. And then when we looked at the Parkinson's patients versus the Alzheimer's patients, again, it's very similar. We saw this very clear signal difference. The challenge, of course, is that DDC is the primary enzyme which metabolizes levodopa to dopamine. And every single patient in this cohort was taking dopamine replacement therapy. And so we couldn't disentangle this from, is this a disease marker, or is this just telling me that somebody's taking a dopamine replacement medication? It could be either, it could be both. We didn't know at the time. And in fact, we saw a pretty strong relationship between the elevation of DDC in our patient cohort and their different motor scores. But their motor scores are also related to how much dopamine they're taking. So we still couldn't disentangle this question. And in fact, DDC isn't just responsible for the metabolism of L-DOPA. It's also involved with a couple of other neurotransmitter metabolisms throughout the brain. And so, which made sense why we also saw this slightly elevated in our Alzheimer's patients. And so what Jared was able to do is identify this group of CSF from the PPMI study, which was from truly treatment-naive individuals. So the PPMI study is the benchmark study from the Michael J. Fox Foundation, really the one that was very helpful in identifying that the synuclein seed amplification assay protein assay, but also has all these big samples of CSF. And these are individuals who recruited right when they were diagnosed with Parkinson's disease, but they had not been treated with any dopamine yet. And they all agreed to get CSF. And this was like a crazy idea, by the way, in 2009. Everyone told them they were nuts to require everyone to get CSF. And now they look all brilliant because they did this. But they had all these patients who agreed to CSF. And not only that, they agreed to get a lumbar puncture every single year while they were in the study. And we've had pretty good, about 80% of patients were able to complete that through the first 5 years of the study. So using these samples of these drug-naive, dopamine-naive individuals, we did still see this elevated signal in DDC in those individuals who had Parkinson's disease clinical diagnosis versus those who were healthy controls. Unfortunately, in the plasma, we did not see the signal in the de novo patients. So it was still there in the CSF, but not in the plasma. These are the 3 other studies from totally different cohorts throughout the world who found the exact same result. So not just in Parkinson's disease, but this was elevated in people with dementia with Lewy bodies, and this was looking at a couple of different places. And in fact, we then looked at what we currently are calling prodrome. So those individuals with REM sleep behavior disorder or hyposmia who do not yet have Parkinson's disease. And in the CSF, we found it elevated in them as well. So we saw evidence of this protein prior to the onset of the diagnosis. And then in one of the other cohorts, they actually looked at these synuclein positive healthy controls versus synuclein negative healthy controls. And they also saw the elevation of this protein. So clearly there's something that's going on here. And this was a pretty exciting hit to get, particularly because it seems to be related to dopamine dysfunction and something that's happening prior to the onset of the symptoms. We then decided to look whether this was stable across different proteins. We also did this using the SOMA scan, and we were able to see, again, continued elevation, but not with nearly the effect size. And when you looked across all of the different platforms, including one that was using mass spec in urine, we saw pretty much everything other than the plasma. Other than the plasma in the de novo patients, every other one of the matrices that we looked at and ways of measuring DDC, we saw the elevation. So pretty convinced that this is a real thing and that this is something that can be actualized. And we're now talking to different companies about potentially using this as part of clinical trials and to look at potentially looking at the change in dopamine function in these patients. So this is one example of something that hopefully that's come out of a proteomics search that can be actually implemented into clinical trials to try to flesh out these pluses that need very clear quantification or some sort of identification of change over time, and possibly, very importantly, from drug companies' perspective, some sort of signal as response to treatment, which right now we do not have. We don't have any biological marker that really tells us that you have target engagement or that you have any kind of biological response to therapy. And that's one of the reasons, quite frankly, why Parkinson's research has been so symptomatically focused, because until you have that, it makes the readouts of clinical trials very difficult. So this has been a huge step forward for our field. We have a long ways to go. I'm just going to do a quick pitch for the samples that we have here at Stanford for those of you who are interested in getting engaged in Parkinson's research and doing proteomics. I highly encourage it. Our Alzheimer's Disease Research Center was rebranded the Healthy Brain Aging Study because we also have about 100 Parkinson's and Lewy body spectrum individuals in that cohort. I'm one of the co-investigators with our Alzheimer's group. The Stanford Aging and Memory Study, which is led by Beth Mormino and Anthony Wagner, also has biosamples, both CSF and plasma, across a cohort that's been followed up to 10 years. And we now have the LB Spark, which is a partnership that is now in parallel with the ADRC, where we're actually going to get plasma samples from every patient who comes into the Parkinson's clinic over the next year, and try to have a very sort of high volume but lower clinical density of samples across that cohort. And we hope to partner with all of you to try to really leverage this to move the needle forward in understanding proteomics in people with Parkinson's disease and dementia with Lewy bodies. So just to conclude, this idea of this neuronal synuclein disease biological definition really comes out of this transformational ability to finally identify people who have this underlying biology of disease, but it is just the initial framework. This is like step one of probably several dozen iterations that will happen over time. But it does finally allow us to identify early biologically defined individuals, potentially stage-dependent endpoint for clinical trials. But importantly, this was constructed for the purpose of evolving as things develop over time. This was really meant to be kind of just the first shot framework, a framework that is very much in line with what has been done in Alzheimer's and Huntington's disease. And in fact, the parties between those are currently having conversations on how we can maintain that alignment as the technologies move forward and the discoveries move forward, but then also how we can think more broadly about neurodegenerative diseases of aging and ultimately come up with a way for these to be appropriately screened on a population level, as well as be ultimately prevented in a personalized way. So thank you very much.